I am Jeff Martin, and I am the Director of Communications and Public Affairs for the American Anthropological Association. And I'd like to welcome everyone. I am an older white male, as evidenced by my graying brown hair, and I am wearing black framed glasses and a collared dark gray shirt. And I'm reporting to you from the lovely confines of my bedroom on a rainy day in Washington, D.C. Welcome to Anthropologists Working in Hospital Settings. This is the third of an 8-part Pathways to Career webinar series brought to you by the AAA. And this series is going to run through April 22nd, covering everything from public sector positions to working with cultural resource management. You can see the remaining webinars and schedule on the slide being presented, and learn more about the webinar series by going to our website link, which I've just posted in the chat feature. All of these webinars are going to be held on Thursdays at 1 p.m. Eastern Daylight Time. Back to this webinar. To make this more accessible to everyone, we're going to provide closed captioning. And what you can do if you want the closed captioning feature, move your cursor to the bottom of the Zoom screen and click on the icon at the bottom that says closed captioning. If you would like to ask your questions verbally or hop on video, please use the raised hand feature and the reactions icon at the bottom of your screen. Also, just a reminder to help us with our bandwidth and overall productivity, please turn off your video and your microphone, mute yourselves unless speaking. This will help us a great deal. We will have time for questions and answers at the end of this webinar. And that's when we're going to hold it after the presentations. But in the meantime, I encourage you to use the chat feature. If you have a question, mark it as question first, question colon, and then ask your question. It'll help us see the question a little bit better. So that'll help us as we get started. Without any further ado, here's Elizabeth Bridey.
Hi everyone, I'm Elizabeth Bridey. I'm a white woman with brown eyeglasses and short hair, and today I've got on a blue sweater. I'm in my alcove, which is a little space in my home, and it has a window. Today we have a great webinar for you about anthropologists doing different kinds of jobs in hospital settings. We have 2 speakers for you. They will each speak for approximately 12 minutes. And then after that, we will go right into the chat where any questions you pose during the time that they are speaking, we will attempt to answer them. And keep in mind that we will have written answers to all of the questions that you ask today that will be put onto the communities page probably sometime by the middle of next week. So you can check back onto the communities page, and on that page you will also see the PowerPoint slides, which you'll be able to download. At some point you'll see the recording of today's webinar, and you will also see a series of references and resources that you can download. So right now we're gonna go to our first speaker, who is Nadine Bendicky, and she is from the University Hospitals of Cleveland. Nadine?
Thank you, Elizabeth. May I have the first slide, please? My name is Nadine Bendicky. I am a white female in my middle 60s. I have gray hair and wear tortoiseshell eyeglasses. Today I'm wearing a red top and I'm working from home, as I have been since March 17th, 2020. Next slide. So let's talk a little bit about my role and my job as the founding director of market research and consumer insights at University Hospitals in Cleveland. UH is a 2,000 bed hospital in Northeast Ohio. that sees 1.2 million patient visits a year across all the different specialties. The way we talk about our work, the Department of Market Research and Consumer Insights of University Hospitals listens to the voice of the consumer in all of its manifestations. Most especially, the department consistently represents the voice of the patient and their family or caregiver. We seek to understand human behavior in order to better inform consumer healthcare decision-making. Next slide. So how do we do this? What kind of methods do my team and I, there's 3 of us, I call us small but mighty. We are the entire market research team for the entire system. We do lots of surveys. We use Qualtrics for many of those. We also have text analytics software. What text analytics allows us to do is to automate the process and do it more quickly as we try to theme responses. Bear in mind that we have 28,000 employees, and we do some employee surveys as well. And we also have an online panel of 3,500 people. So the open-ended qualitative questions can take a lot of time, as we all know. We do focus groups. Up until a year ago, we did them in focus group facilities throughout Northeast Ohio. We are now doing them virtually. I've also conducted one-on-one interviews with many stakeholders, patients, families, doctors, board members, community members, many stakeholder groups. We're still doing a lot of secondary research. I often tell people that we're not the first hospital to think of something, and before they send us off to do primary research, let's see what else is out there in terms of the disease's prevalence and incidence. We understand trend demographics, changes to the population in Northeast Ohio, and we're very interested. We're conducting some research now on what's called primary care, so that's your internist or family medicine physician, and the amount of competition that's happening there from Amazon, from Walmart, you name it, everybody wants to be competing with hospitals. And a relatively new capability is what we call social media listening. So we have 2 people that post on our social media sites, primarily Facebook and LinkedIn. And as we all know, if you like human behavior, it's really the comments that we take a look at, which are as interesting as the stories we post. And we have people who monitor social media to see what people are saying about the hospital, about our service, about the diversity in our workforce, about the pandemic. So that's a relatively new capability, and we're very excited about it. Next slide. So if you asked me what skills you would need if you wanted to do this job, I would say, I know, you need good written and oral communication skills, because we have to report out to many different constituencies. You need qualitative and quantitative analytical skills. I am by training and inclination a qualitative researcher, and I've had to embrace the quantitative side of the house that pays the bills. And some of the things we're doing along with our data scientists allow both skills to be used and to come together for richer, deeper insights. Something I cannot stress enough in what I do this every day. Doctors speak one language and patients speak another. So my team is called on to translate very complex language about diseases or treatments into language that families and patients can understand, especially if you want them to comply with what you're asking them to do. The doctors really are not good at this at all. They think they are, but they're not. Nurses are wonderful. And this is something that is so critical to my function. So you learn a lot about clinical medicine when you do what I do. This year, we have pivoted and pivoted and pivoted. We've had to be exceptionally flexible and adaptable. And those of you who haven't had your first professional job yet, at the bottom of a job description, it says all other duties as assigned. That's 90% of my life. Things happen and someone says, Canadine's team, find a way to get this feedback. So we do a lot of problem solving. We use Word, Excel, PowerPoint, the text analytics software, which is called Ascribe, A-S-C-R-I-B-E. That's a proprietary product. It's under $10,000, and it allows us to quickly theme massive amounts of open ends. We're starting to do more data visualization. We use databases as well. And I think it's important to tell you that even with all the technical skills that I have and my team have, if we don't have interpersonal skills, I can't get the work done. We many times are quarterbacking ad hoc teams of people throughout the hospital, and I have to use those skills in order for persuasion. I need to learn how to listen. I need to say I'm wrong. I need to ask people their opinions. And so it's really critical to our function to not only have quantitative skills, but interpersonal skills. Next slide, please. Okay, so if you were looking for a job at the hospital, you would not be looking for a job that's marked anthropologist. You might be a policy analyst, looking at laws and regulations and putting them in briefs. My team has market research analysts. You can work in a planning department that does more demographic analysis. They do, in our case, they do a lot of mergers and acquisitions. You might be called a research assistant or a research associate. We do a lot of user design work now with a tool called UserZoom. And we look at our website, we look at our apps, we look at everything we have that's patient facing. And I'm doing it on the fly. I'll just tell you, I'm just doing it on the fly. And I have seen job descriptions for hiring called design analyst. I've talked about myself as a researcher, but ultimately when you reduce everything I do down to one main theme is I'm a patient advocate. There are other patient advocates located throughout the hospital. Some help with billing, some help with accessibility issues. If you have a person who has not sighted, who needs help interpreting their bill and paying it, we have people who can help them with that. And those are scattered in departments called like patient experience. We also have patient experience analysts at the hospital. Each hospital has one. The term you might hear is ombudsman, O-M-B-U-D-S-M-A-N. It's kind of a funny word. And that's a person that in a sense represents the patient in a different capacity. If they need help beyond what a frontline person can do, that person might take them on as part of a case, if you will, and help them navigate what is a very complex healthcare system. And we actually are fortunate enough to have a health literacy coordinator. She's based in our cancer center, and she will consult with anyone throughout the hospital to make instructions, website content, homegoing discharge instructions, whatever it is. She will work with them to get it at a 6th to 8th grade education, which is what the standard is for health literacy. Next slide, please. So you probably want to know the kinds of projects my team and I do. We've interviewed parents of pediatric cancer patients and interviewed the adolescents and the young adult patients themselves regarding the staff's willingness to communicate effectively about case prognosis and progress. I have to tell you, we would never schedule 2 of these interviews in a row because once you finished one, you had to go sit somewhere and think. It was very emotionally difficult work because some of the young patients were not likely to survive. And we knew that, and yet they all brought their whole self to the interview as we talked to them. We do user experience of our website. We have our own apps. We did an excellent study of our electronic medical records, the Epic system. We're moving to Epic, Allscripts. We got 7,500 open-ended comments. Use the text analytics to help us and put together a very robust qualitative analysis on what patients know about EMRs and what our EMR was not doing. I've just recently we do secondary review of the literature. I'm focusing now on vaccine skepticism, hesitancy, and distrust. Very complex. Next page, please. We do have a 3,500 member patient panel, which we use for many, many things throughout the year. 75% of them are our patients, 25% are not. And they might come to us and say, a group within the hospital, we have patient family advisory councils. And they might say, I need another 5 patients or family members on my council. Can you reach out to your group? I said, sure. We reached out. 100 people said, I would like to be on that committee. I turned those names over. It was then their headache. But we were able to get a robust response, and then they interviewed people and made their decision. Annually, we do a quantitative study of consumer awareness, consideration, perception, and preference, and the likelihood to use various hospital service lines. That's 1,200 people, and frankly, we farm it out. It's too big for us to manage, but we are very involved with the survey instrument, revisions, and rewriting the report when it comes in for the different target audiences within the hospital. And we do a lot of ad testing before something goes live. We might have 2 different pictures, 2 different treatments, 2 different styles of fonts, whatever it is. And we might test a couple of different ways to portray it and have the panel members let us know which one is most likely to make them take a certain action. We call that a call to action. Next slide, please. So I'm 40 years out of graduate school, so you do the math. And you might think that I'm really not very close to anthropology anymore. I've made my living, as a market research analyst for over 40 years. And I can tell you there is not a day that goes by that I do not use my undergraduate and graduate training. Not a day. How do I do that? I need to understand multiple divergent points of view without having my own point of view. You have doctors, you have patients, you have the government, you have clergy, you have unions, you have family members, you have volunteers. Hospitals are extraordinarily complex organizations, and I have to adjust each time I'm working with a different audience to see the world through their eyes, right? The term that I looked up again, because it's been a long time, thick description, came back to me from Clifford Geertz, that anthropological research is answering why, and it's going deep rather than wide to know more about it from person's point of view, whichever point of view that is. We go to where patients are. So up until a year ago, I've been to the ED. I spent a day in the ED. There was a shooting and the patient came in conscious and talking, and I was pulled in to watch that happen as 28 people literally debriefed him to find out how he was and what kind of pain he was in. I've been to community health centers. I've been to our skilled nursing facility. I call it management by walking around. Now that we're virtual, it's much, much harder to do. And it's going to continue to be difficult for me to get into different communities with Zoom. And there's the ever-present problem of not all of our communities have the luxury of Zoom connections. So we are truly losing some of our connections to the community, unfortunately, because of the pandemic. I went to graduate school at Case Western Reserve University in Cleveland, Ohio, and we spent a lot of time talking about disparities and inequities. And Cleveland is an incredibly poor city. We have a very, very high rate of maternal and infant mortality around birth. We had it 40 years ago. We had it 20 years ago. We still have it. And so I'm frequently called into projects where there are issues related to disparities and asked to help problem solve other ways we can provide services to people in the community. And we throw the term patient-centric around a lot. I'm not sure I'd go to a hospital that wasn't patient-centric. However, that's the distinction from hospitals which are physician-centric, and make no mistake, physicians continue to be very powerful in hospitals. And part of my job is to balance that with the patient's point of view. Next slide, please. So if you wanted to get started and say, what do I have to do if I want to think about this? Keep taking qualitative and quantitative methods. Yes, you need to take statistics. I would suggest taking an internship or a volunteer position at a hospital, a community health center, a skilled nursing facility, any one of those. Please update your LinkedIn profiles. I I'm amazed at the number of people who don't have LinkedIn profiles, and it is a community of its own. And you can build a network of people who have interests like yours. I actually post every week, sometimes two a week, on things at the intersection of health, medicine, society, and the human condition. And people read about that and reach out to me in other ways. It's almost like a blog. I'm still taking online webinars for continuing education. And one of the hardest things to do, and I still struggle with this even after I've proved my value again and again, is how do I translate the value that someone trained like me can provide to a healthcare setting? So I have one person who has a PhD in health communications and market research. I have a second person finishing a master's in consumer psychology, and I'm the medical anthropologist. In many, many market research departments, you have MBAs. There's nothing wrong with that. That's an alternative way of getting in. But I have to tell a potential hiring manager what I bring that distinguishes my skill set from a more typical, person who's trained more typically in business. And that is a challenge. Think about explaining what you do to your grandmother, and then you see how difficult it is. Next slide, please. Okay.
All right, then that brings us to me. Hello, my name is Joshua Liggett. I am a nerdy 30-something. It says 30, but it's really 31. Multi-ethnic fellow. I have Japanese ancestry, and then the rest of my family is from Europe. I use the pronouns he and him. I came out in college, married my husband in 2013, and then we welcomed our son into the world in 2019. I'm wearing a striped collared shirt, a black UCSD zip up, and behind me is a Zoom background, a little bit California centric. Its goal is to get folks to download the CA Notify app so that we can all know if we've been exposed to COVID-19. And then beyond that curtain is a wall of board games, which shows how nerdy I am, but I won't take that down for today. Next slide, please. Yes, perfect. So I received my BA from Fresno State in the Central Valley of California in 2012, and my master's from University of North Texas in 2014. I wended my way through graduate school, having different projects for school districts, one school in particular, and a hospital system in Texas. I went on to work for a behavioral health research organization called Uplift Family Services. It was there that I definitely got a lot more quantitative skills hammered down, which was helpful. LTG Associates, an evaluative consulting firm, definitely brought me back to my anthropological roots. And UCSD Health is where I am today. And I work in the quality department. In and amongst all of that, there's also some volunteer work that I do for the National Association for the Practice of Anthropology. Next slide, please. Cool. So this is just a brief overview of our program at UCSD Health, Center for Organ Transplantation, where I work as a quality and regulatory data analyst. We've done about 140 transplants this past year for kidneys alone. And then these are the kinds of things that we look at when it comes to how well our program does. So how survivable is our wait list while people are waiting for an organ, how quickly they receive an organ from a deceased donor, which is our most common transplant type, And then within the first year after transplantation, how many patients are still doing well, and that sort of a thing. And so these kind of boil down some really robust questions of patient health, access, and so forth. Yeah. Next slide, please. So just a brief overview of the things that I do in the quality department is really revolves around things within the scope of something called Lean Six Sigma. And it's essentially process improvement. So we do things like the plan, do, study, act, where we identify that there's an issue that needs to be addressed, come up with different ideas by involving the voice of the customer, which for us can be internal and external. So we're talking about patients and our own colleagues within the transplant department. And so that can take the form of what's called a 5S. It's a series of consonation that just basically means it's an organization of virtual or physical space to make things more efficient. And so we'll have conversations, we'll develop diagrams to address like movement patterns within a space to make sure it's the best function, most efficient, that sort of a thing. My department is pushing to get everyone trained at the black belt level within that. And so we become resources for the rest of the transplant department, across organs and different components of the program, either administrative or patient care. One of the more interesting things that we're getting to do right now is a rapid process improvement workshop. So we're having, intense meetings where we're interviewing folks and getting a lot of information from staff about different processes right now, particularly around multi-organ transplantation. So those interfaces between like our liver transplant team and our kidney transplant team, and making sure that handoffs happen the way they should, and really getting a sense from the team what should be happening, what isn't happening, what could just be done better. And then, interspersed amongst all of that is just standard patient data auditing, monitoring, and reporting. We have a number of annual reports that we do. We have dashboards that we refresh just to kind of track the performance of our program. Just be, yep. Next slide, please. So I guess a good question, and one that Nadine mentioned earlier, is how is my work anthropology? This is a question that I have definitely struggled with over the years, but at the core of it, all this is evaluative work. We're sitting next to our colleagues, we're talking to them, we're watching what they're doing, and having formal and informal interviews just to kind of see, what is the process actually like, what is the work actually like. And I think a good quote from Margaret Mead is, people will say one thing, do another, and say they do a third thing altogether. So definitely being able to parse that, turning up the volume of the voice of the customer. So being able to highlight what patients are saying, what the individual staff members, our colleagues are saying, just so we can make sure that we're arriving at a more perfect process. We're all human, things happen. We're not going to be perfect, but we can always strive for more. And so helping to reframe customers, internal and external, their view of a perfect process in that regard. And it is quantitative work, mostly. but as a colleague of mine said in an elevator one time, anthropologists count too. So that is helpful for me to frame up the work that I do. Next slide, please. So what do I find rewarding? Well, primarily we have a very supportive management and C-suite team when it comes to the quality department. They're focused on our growth and learning and things that we can bring to the department to kind of change how we improve the program going forward. We have in that opportunities for growth and learning. You know, the black belt trainings for Lean Six Sigma. We also have report writing training that we're starting, interfacing directly with our electronic medical record system. Nadine mentioned the Epic system. We're definitely working with that, so it's fun. And all of these are different and new challenges for just us to kind of take a look at and re-envision the work that we do. And then encouragement of long-term goals, you know, kind of the usual questions of what do you want to do in 5 years, with the idea that we don't want to stay in the same roles doing the same thing. So how will we evolve going with the program? And then process improvement, I really kind of nerd out on this stuff. So that's something that I enjoy. And you know, the impact of transplantation. You know, you're changing lives of patients within the scope of just kidney alone. You know, survival is acceptable on dialysis, but long-term, a new kidney is going to be better for you. So even if it's just new to you. Next slide, please. Yeah, so useful ways to prepare. Some of the things that I did was starting with the Lean Six Sigma training myself and getting those certifications. I credit this partially to Groupon's marketing algorithm. Every time they would send me an email, it'd be like, you should get this one. And I did, and now I'm here. So that definitely helped. Thank you. Underscoring what Nadine had mentioned before, solid Excel skills are going to be useful in this sort of role. We do a lot of data collection, data crunching, you know, dashboard applications. We're branching out into Tableau, but I've worked with companies that use Microsoft BI and things of that nature. Learning a coding language, statistical or SQL. That sort of a thing is helpful. I'm seeing a quick question that I'll address. What techniques do I use to reframe a customer view of the perfect process? For most of my work, I would say this is a one-to-one process, or at least one to the group. And it usually manifests as like, if you had a magic wand and wanted to design something that would be perfect for your needs, for the needs of the customer, needs of the patient, how would you design this from beginning to end? And then we have a very long conversation that involves a workflow diagram and back and forth about which parts go where and so forth. Social media definitely could have an aspect there, and I think Nadine has some experience with that with regards to social media listening, and that could be something that the UCSD employs soon. So thank you for letting me steal your idea, Nadine, in advance. And going back, definitely knowing how to report quantitative data. Nadine had mentioned taking statistical coursework. Mean, median, and mode are some of the biggest important ones for the reports that we do. Anything around frequencies and so forth. And suggestions would be to review requirements for like data and quality analysts, similar roles. Nadine had shared a nice breakdown of things like that, and some of them match what we do as well. And then reviewing national data and resources on transplantation. There are some really interesting websites, one linked earlier along with the outcomes for UCSD Health Center for Transplantation. They have a wealth of information at the Statistical Registry for Transplant Science, I think, at srtr.org. They're particularly helpful, and there's also the National Database Unified Network for Organ Sharing, UNOS.org. They both have a wealth of information on programs that are available, and just transplantation within the United States, though it is restricted just to the states. So next slide, please.
Okay, so now this is Elizabeth. Now we're going to open it up to questions from attendees. I think we've heard two very distinct kinds of jobs in hospital settings. So let's go ahead and get your questions into the chat. And please put the word question ahead of your question. So the first one, how much of the quant training did each of you have in graduate school, and how much through other institutions or programs? Nadine?
Yeah, so I'm happy to answer that. So remember, this is 40 years ago when the world was a different place. I was required to take undergrad stats and then graduate statistics in order to complete I got a BA and an MA in 5 years, but I took 2 stats class. One of the most important things I can say to you is that someone said to me is, you may never have to perform all of these statistics, but you're going to need to understand when to use them and how to use them. So the recommendations would be, if it isn't part of your curriculum, that you still get a way to get exposed through either a certificate kind of thing or being part of an online group that looks at methods and looks at statistics, because it would be very hard for me to work in a hospital and not talk about empirical data when I'm dealing with MD, PhD scientists. So I've picked up a lot along the way, and I would encourage you, if you can't take it as part of your curriculum, to find other ways where you'll at least be exposed to quantitative methods, so that you could, in a sense, begin to critique, well, oh, I know why they did it this way, in order to get the mean they had, or to understand sometimes why you need to normalize your distribution when you have small groups. Somebody asked me the other day, we have 100 people running statistics. I said, don't be ridiculous. It's too small of a group. We're not doing it. It's the wrong, in a way, it was the wrong question to ask.
And Josh, how would you answer that question about training?
Hi, this is Josh. Definitely, it was helpful at the University of North Texas. They included a quantitative methods course. That was a good baseline. I had also taken decision sciences courses separately during my undergrad. And then, my first real job out of college, Uplift Family Services, was very quantitative focused as well. So I got to bolster not only just my statistical skills, but also use of different platforms, particularly SPSS, statistical package for social scientists.
Okay, great. Margaret has a question. What are some of the challenges of doing anthropologically minded research within the bureaucracy of a hospital?
I could go on for days. I won't. What I try to do, particularly with people who are skeptical, is that in the beginning, I don't necessarily explain what my training is. I do what they ask me to do if it's, you know, legal and moral and scientifically solid. And afterwards, I might say, you may not know, but my training's in anthropology, not in business. And they'll go, really? What are you doing here? And so I try to sell myself by actually undertaking a project or showing reports that I've done, showing PowerPoints, those kinds of things. Hospitals are incredible bureaucracies. However, hospitals require a lot ability to switch gears. And to me, that's the most fundamental skill I have. Is today it's quant, tomorrow it's qual, Monday is a vaccine census, Tuesday is ethnographic research on why people don't use vaccines. So it can be done, but the best way of doing it is actually working on a project, getting people to trust you, and then talking about what your skill set is.
Josh,
Yeah.
anything to add to that?
This is Josh. I would definitely underscore that. You know, you want to do what you're asked of first, and then almost surreptitiously, you can even include something of ethnographic work by, you know, one of the first few things we did was just a conversational interview to find out how people were feeling within the program. And that wasn't necessarily billed as ethnography, but definitely identifying areas of improvement for the program. So.
Chloe has a question. Do most of the job areas specified in the presentation, I think she's referring to yours, Nadine, require a graduate degree? Is entry into this field possible with just a bachelor's?
All right, so I have to plead a little bit of ignorance. I haven't hired a BA prepared person in a very long time. If I were able to add a fourth person to my team, I would have a junior analyst who was baccalaureate prepared and probably had worked in the field, either in market research or a hospital for X number of years. But if your question is really, I have a BA in anthropology and I want to work in your department, it's a tough sell. It's going to be a tough sell.
Josh, any comment on BA versus MA, MS?
Yeah, this is Josh. I had experience on the other side of things where both my position at Uplift and UCSD Health, both of the job descriptions required a bachelor's, but I was hired with a master's for both of those positions. And it doesn't seem like there was really a lot of interest in pursuing someone who had a bachelor's for those positions.
Okay. Freddie has a question for Nadine. Are there any resources to train in clinical medicine language if you want to be able to explain things to patients? Anything that you could point to in the literature or a website?
This is Nadine. That's a very good question. Mine was, I'm the daughter of a triple boarded forensic pathologist and a nurse. So I grew up talking about things like this, and then learned the rest of it on the fly. I'm not aware right now of specific things, but I bet if you went to Google and put in doctor speak or clinical speak, you might get something to help you, because this whole area of health literacy, which I think is really hot and would be really, really good place for anthropologists to look, that requires that understanding of both sides of the coin, how patients speak and how doctors speak. So why don't make an experiment, go to Google and put in doctor speak and see what pops up.
Megan has a question. How do you sell or explain your anthropological training to people who are not anthropologists? So how do you help them understand your qualifications for a position? Josh, you want to try your...
Sure. This is Josh. I have a little bit of experience with doing this with regards to, well, I take that back. I have experience with this with regards to translating this into things within the scope of a quality department. Particularly, one of the benefits of having that sort of training to lean into is, referencing what Nadine had mentioned before about thick descriptions. One of the things for Lean Six Sigma is they have a process called the 5 whys, where you're digging deeper and deeper and deeper into a problem to bring more of the root cause to light. And so part of that is an ongoing conversation that kind of broadens the discussion beyond just, there were 5 cases of this and 6 cases of that, but why is this and why is that and why? And you keep going until you find a root cause. So I guess the crux of that is finding a common language with who you're wanting to work for.
Nadine, do you have anything you want to add?
No, I think he did a really good job. He did a very good job. Thank you.
And I would just point out that the first career webinar that we did September 2020 is about this particular issue. So we've got a whole webinar talking about persuasion. It's called The Art of Persuasion, Articulating Anthropology's Value to a Prospective Employer. And so if you are a AAA member, you can easily access the AAA website and take a look at that one. Next question from Ulrich. You both work in positions that consist to a significant part of quantitative analysis and statistics. As for the quant part alone, it would maybe have been more logical to hire an MBA. What would your employer or others around you have missed if they had hired an MBA instead of an anthropologist? That's a great question.
So this is Nadine again. It's a very good question. It kind of depends on the person who's doing the hiring and what the kind of typical workload is. Now, remember, I was hired 8 years ago today to found a department that didn't exist, right? So I got a desk, a computer, a piece of paper, a pencil, and someone said, go forth and do great things. And so I think one of the reasons they hired me is because I say to them, quantitative research can tell you that. Qualitative research allows you to ask why. If you only want to know how many X or Y we do and what the survival rate is and why you should come to us, that's one question. If you want to understand why people are not getting vaccines, you cannot get that answer by asking quantitative questions. So I try to let them know by giving solid examples of what determined marketing is called a value added. My value add is that I can push and say, it's not enough for you to know the statistic. I want to help you understand why, and then maybe we can problem solve a better way to provide the service to your patient.
Super. Wendy has a question for Nadine. Are jobs like yours common at major hospital systems?
Yes and no. So 35 years ago, I started at the Cleveland Clinic in a very robust market research function. And so they were really, really, really ahead of the curve then. When I was hired at UH, it's because they didn't have the function. And as time has gone on, everything goes through cycles. Let's farm everything out. We'll just work with a vendor. We'll have a research director, but they won't have any staff. Then they say, no, 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 we need. So it kind of goes in cycles. I will tell you the larger, so when I say Academic Medical Center or AMC, Mayo Clinic, University of Chicago, all the things that are associated with Massachusetts General Hospitals, they have departments of either market research or consumer insights. Insights is really hot, really, really, really. And I've actually talked to a company that said, I prefer to hire social science people rather than MBAs because they allow me to do the work of drawing insights. So the answer to your question is yes, sort of. It's a small pool. There's about 150 to 200 academic medical centers, and they all have, many of them have a function similar to mine. It might not be called market research.
Josh, anything to add to that?
Yeah, this is Josh. I would definitely say much of the same. My hospital has one for our transplant department. Most quality departments consist of a single person that does something very different from what we do. For the most part, it's reporting functions, almost administrative, more than process improvement or anything on that order. So you definitely want to take a look at the hospital you're applying to. I know, just out of the virtue of my supervisor having come from there, but Stanford has a very similar, very robust quality program, like UCSD, within the scope of transplant. Of course, each medical department is going to be different too. So.
And then we have a question from Jess, who asks, what was your graduate school research focused on, and how do you think it helped get you into the job you're in today? Or is it just so different from your work?
Yes. So I'm gonna make Elizabeth and several other people on the call, this is Nadine, feel old. There was no internet when I was in graduate school. Period, paragraph, end of chapter, turn the page, okay? So in some ways we're dinosaurs, but in other ways we are not. And so I have to say this is more about my personality than it is about being interested in anthropology. I'm intensely inquisitive, and I'm very interested in human behavior, particularly in the hospital. And that's how I kind of wiggled my way through things in the beginning. Once you have experience, as I did at Case Western Reserve, then I was at an insurance company, then I was at Cleveland Clinic, and now at UH, it became less and less important about what I studied. Or my exam, I didn't do a paper. I don't even remember, okay? So it was that not memorable, but that was not, it didn't help me or hurt me. It was neutral. It's what can you do to help me undertake market research, quality, policy, be able to really distill what your competitive advantage is. And I know this is uncomfortable. I get that it's uncomfortable, but if you can't make it easy for the hiring manager, they'll just move on. And so I wouldn't let your undergraduate or graduate research limit you in terms of what you look for, because your skills are transferable.
Josh, anything to add?
Yeah, this is Josh. I went to an applied program for my master's, and somewhat of an applied program-ish for my my undergrad. And my master's thesis was at its core evaluative work. So I was, like Nadine had mentioned, it's a transferable skill. So as long as you can communicate what you're doing, it doesn't really matter the actual content. It's the skill set. Because my thesis was on geeks in a high school program, which is very different from organ transplantation.
Thank you. Next slide, please. So this is Elizabeth and a quick summary of some of what we learned today. Hospital jobs can be very meaningful if you can connect the work you do with the hospital's overall mission. They involve translating content from doctor speak into a language that the patient or family member can understand and act on. Hospital jobs are interdisciplinary and require a balance of interpersonal and analytic skill sets, as well as good judgment. Next slide. Quality programs could use more anthropologists. Knowledge of lean tools are a major boon for joining the quality ecosystem. Anthropology is symbiotic with Lean Six Sigma. And math is not an anathema to anthropology. Learn how to code. Next slide, please. So we're delighted that you were able to participate in today's webinar. You will get an evaluation because we have your emails and we're hoping you'll fill that out. On Communities, you'll be able to see, as I mentioned, various pieces of information that should be useful to you. And then please register for one or more of our upcoming webinars this spring. Next slide. Here's a list of them. The next one is on cultural resource management. And a big thank you to the AAA staff for all the work you do in putting on these webinars. We really appreciate it. And thank you so much to all the attendees. And we look forward to seeing you in the future.